I'm so sorry for the delay. Uh, uh, my name is Dr. Shirini Vedakan. I'm an endocrinologist from the University of Malaya. Thank you for inviting us to collaborate in this webinar.
Sure. Yeah, Professor Zarina, thank you for joining us. I'm Jacob Chang here. I'm the vice superintendent. I'm myself I'm a urologist.
I see. Okay.
For some background information to you, we already started this joint webinar since 2 years ago. I think almost 2 years now. So it was our pleasure and privilege to have a connection with UN. And I know that the pandemic had stopped us from meeting each other in the past 2 years. But I want to tell you a good news. I think probably Taiwan will open up the border and more relaxed policy coming. So I hope that I have spoke to Professor Ong about physical meeting together in the future. So hopefully next year we will visit or end of this year we will visit and by that time we can have a more close contact and we can discuss and deepen our strengthen our collaboration. So today is really our privilege again to meet you and your colleague. And I also have my colleague here, Professor Liu. Actually, Professor Liu is just elected as the president of Endocrinology Association of Taiwan. So today I hope that you both sides can have a fruitful discussion. And of course, we are looking forward to our physical contact and more collaboration. Thank you very much.
Yes, may I say on behalf of as well, it's a great pleasure for us. And we look forward to hosting you physically here in Malaysia as well.
Sure. So maybe we will just start the discussion and seminar. Maybe I'll let Professor Dr. Serene to introduce your colleague. And I will apologize myself. I think I will leave you all here and I will go to another meeting. So, but I'm sure that Professor Liu and my other colleague, Professor Chou, will have a good interaction with you in this afternoon, this meeting. Thank you.
So welcome everyone. Thank you for joining us here during this thyroid webinar. Let me briefly introduce my colleagues and friends. Two eminent speakers from the Department of Endocrinology, University of Malaya, Malaysia. Our first talk from will be by Dr. Shamila Paramasivam, a senior lecturer in medicine and endocrinology. Her research interests include the use of technology to improve outcomes in diabetes in pregnancy, osteoporosis, and thyroidology. Shamila will be talking about something very topical and interesting, the relationship between SARS-CoV-2 and thyroid disease. In the interest of time and efficiency, I'll also introduce our second speaker, and she will give her talk immediately after Dr. Shamila if there are no questions in between. Our second speaker, Professor Dr. Lim Li Ling, is also a consultant endocrinologist and head of the Diabetes Care Unit here in University of Malaya. Her research focuses on cardiometabolic medicine and intergenerational diabetes with translational and implementation science components. Li Ling will be updating us today with the very latest on immune checkpoint inhibitor-induced thyroid dysfunction. Without any further ado, let me now hand you over to Dr. Shamila.
Thanks very much, Prof. Shirini. Thank you for the kind introduction. Very good afternoon to my colleagues in Taiwan, Chang Medical Foundation. So I'm just going to share my screen. Just bear with me.
知道程序的，慢慢学，这样他学到。
Okay. Are you able to see my slides?
Yes, you can see clearly.
Okay,
Thank you.
great. Thank you so much. Okay, I'm just gonna wait. How do I get this one out? Okay, all right. Okay, so a very good afternoon. The topic that I'm going to talk to today about is a very interesting one about COVID-19 and the thyroid gland, and what are the effects of COVID-19. So we all know about COVID-19, and we know that it affects multiple organs. And what is the latest data we have on its effect on the thyroid gland? So this is the outline of my talk. We'll just talk briefly about the SARS-CoV-2 pathophysiology. Then we're going to go into the effect of SARS-CoV-2 infection on the thyroid. And we're going to look at the spectrum of the thyroid abnormalities seen in COVID infection. What is the latest data that we have? And then we look at a bit of the effect of the thyroid instead on SARS-CoV infection. Okay, and lastly, if we have time, I have two cases that I would like to discuss at the end. Okay, so this is the virus that has changed our lives in the last 2.5 years, the COVID virus. So I don't have to explain much about it. We know all about it. But just to highlight, these are the numbers from yesterday. The total cases worldwide is about 600 million, with 6 million over deaths worldwide. So very high mortality there. In Malaysia, our total cases to date is about 4.7 million cases, and we have about 38,000 deaths. So this is just a snapshot of our COVID Now website, which shows the latest updates. And you can see, compared to before, we don't have as many hospitalized cases. So thankfully for that, but still we do have quite a significant number of cases occurring every day. So you can see with this large number of patients who are admitted, who have been infected with COVID, so we're going to see a lot of complications from this infection, because it's a novel virus. We don't know the long-term effects of it. All right. So first of all, let's look at the pathophysiology. Just very briefly, I'm sure you all know this, but we just go through it very fast. How does COVID get into our cells? So basically, there is it gets in. The entry is proposed to be through the ACE2 receptor. Okay, with the presence of this other receptor, the TMPRSS2 receptors. And what happens is that this allows the COVID virus to be then taken up into the cells. So the proposed mechanisms for how COVID actually affects us is that it could be a direct cytotoxic effect. The virus enters and directly affects the cells. Or it could be some dysregulation of the renin-angiotensin aldosterone system. Okay, or it can cause endothelial cell damage and thromboinflammation. That's why we see high rates of thromboembolic events in COVID, okay, and as well as the dysregulated immune response. So this is when you see the cytokine release syndrome. So these are the proposed mechanisms of how COVID actually affects us. Okay, so to summarize, the ACE2 and the transmembrane protease serine 2 receptors are involved in SARS-CoV internalization into the host cells, and we know that the high levels of ACE2 expression in these multiple organs, the small intestine, the kidney, the heart, salivary glands, testicles, as well as the thyroid, which is why the thyroid is one of the organs that's actually affected by COVID. Okay, so there's lower levels of ACE2 expression in the brain, skin, pituitary, and skeletal muscle. So these are the areas that have less effect. Okay, so and it's been shown that thyroid follicular cells express ACE2. So that's what makes them susceptible to COVID injury. Okay, so looking at COVID, so we know it affects the lungs, but we also have seen a lot of extrapulmonary manifestations. So you can see this is a paper in 2020, quite soon after the pandemic started, and you can see these are all the organs that are affected. So you have neurological manifestations, renal, hepatic, GI, thromboembolism, and you can see under endocrine, at that time what was reported was mostly diabetic related, hyperglycemia and DKA. However, you can see just a short 2 years later, in 2022, they've added the list to endocrine manifestations of COVID. So you can see actually COVID can affect all your endocrine organs, your pit, your parathyroids, your thyroid, adrenals, pancreas, and even the testes. Okay, So we're finding out more and more about COVID as time goes by, and I think we're going to probably find out a lot more in the next couple of years. So let's focus now just on the thyroid manifestations. Okay, so the question is, how exactly does COVID affect the thyroid? So there are two postulated reasons. One is a direct infection of the COVID, of the virus. So it's like an infectious thyroiditis, okay, which we see with other viruses as well. The other cause is actually an abnormal immune response. So what happens is that the COVID infection increases the immune response and causes increase in your interleukins, and that actually results in thyroid gland inflammation. So it's either the interleukins itself attacking the thyroid gland, or it could be antibodies that actually go and stimulate or destroy the thyroid gland. Okay, so how does it manifest? It can manifest as thyrotoxicosis. And thyrotoxicosis, these are the three reported forms of thyrotoxicosis so far seen with COVID-19. Subacute thyroiditis, painless thyroiditis, and Graves' disease. Okay, and we also, and in fact, hypothyroidism has also been reported, primary hypothyroidism with COVID. And the third one is actually non-thyroidal illness. Yeah, so these are the case reports that have come up illustrating the thyroid effects from COVID. Okay, so we'll focus now on thyrotoxicosis first. So this is the most common manifestation, which is subacute thyroiditis, or short is SAT. So this is the first paper that was published in 2020. This was the first case of subacute thyroiditis, a young girl who presented with neck pain. All right, this was in Italy. Yeah, and then subsequently, even in our region, the first reported case was in Singapore, and it was also a similar case of a painful neck with thyrotoxicosis. And subsequently, you can see, this is a summary. There are many other papers, case reports illustrating the similar presentation of subacute thyroiditis. Yeah, so this is just to show that there's more and more data coming out, and we'll probably see much more in the future as well. So looking at this evidence-based systematic review on subacute thyroiditis, COVID-associated subacute thyroiditis, what have they shown? So they looked at 27 case reports, all right, and what they found was this was seen more in women, and these were often seen in very mild COVID-19 infections. So they often presented with just CAT2A, yeah, mild URTI, and then subsequently developed subacute thyroiditis. And the manifestation can occur early, from 3 days to even late, up to 3 months, to 2 months, after COVID-19 infection. And the classical symptoms that were seen that were similar to any other subacute thyroiditis: neck pain, fever, as well as hyperthyroid symptoms. And it was seen that their T4, T3 was raised, and they also had increase in inflammatory markers, ESR, CRP. And the ultrasound showed patchy hypoechogenic areas with reduced vascularity, okay, which is what we expect in a subacute thyroiditis. And all their traps, not all the patients had trap taken, but those that were taken, the traps were actually negative. All right, so the most common treatment that were given for these patients was actually steroids, and they actually resolved well. There was complete resolution, and most cases became euthyroid afterwards. Okay, so to summarize, subacute thyroiditis post-COVID is usually seen in mild COVID, after mild COVID infection. Yeah, and they usually present with neck pain, they have raised inflammatory markers, your total white cells, CRP, ESR, and the thyroid antibodies are usually negative. All right, so how does it work? The SARS-CoV, the virus will attack the thyroid gland, okay, direct invasion, direct attack, and what happens is that you then have a subacute thyroiditis. Okay, so this is the first way of how COVID can affect your thyroid. So the second way that has been reported is actually painless thyroiditis. Yeah, these reports are much less compared to the subacute thyroiditis, which is more common. These are patients who present without neck pain, thyrotoxicosis without neck pain, and it's usually a destructive thyroiditis. And the way they develop is more inflammatory mediated. All right, it's been shown that there's an inverse relationship of TSH and interleukin 6. So the higher your interleukin 6 levels are, the lower your TSH levels are. So it's an inflammatory mediated destructive thyroiditis. And this, compared to subacute thyroiditis, these are usually seen in hospitalized patients. Okay, so when they are in the ward, they will have some tachycardia, or there's some reason why a thyroid function is sent, and from there they are actually diagnosed to have thyrotoxicosis. Okay, so this is a study, the Thyroid study, looking at these patients who had thyrotoxicosis associated with COVID-19. And what they found was that about 20% of hospitalized COVID patients, this was in Italy as well, 20% of their hospitalized patients had thyrotoxicosis in the absence of neck pain. Okay, so the reason why they did thyrotoxicosis is because it was their routine to do TSH in all their hospitalized severely ill COVID patients. So that's how they have this data. So of course, we don't routinely send it for every patient unless it's indicated. So what they found was that patients, COVID patients who had overt thyrotoxicosis, it was actually associated with an increased risk of atrial fibrillation, thromboembolic events, in-hospital mortality, and longer hospitalization. So it's not that the thyrotoxicosis caused that, but these patients were more ill. And because they were more ill, they had more inflammatory mediated thyrotoxicosis. And it was associated with all these poor prognostic markers. So that's the second way that COVID can actually affect your thyroid, painless thyroiditis. Okay, so the third way is actually quite interesting, is that COVID can actually cause Graves' disease. So it's been shown that your virus can actually induce or cause Graves' disease. Okay, so this was a paper looking at 5 patients, and they were all female as expected with Graves' disease, which is predominantly a female population, aged between 20 to 60 years old. All right, and this occurrence of Graves actually occurred much later, about 30 to 60 days post-COVID infection. So some of them actually didn't even have any history of Graves' disease. They were totally euthyroid, but they developed Graves' disease. But however, 3 out of 5 actually had a history of Graves' disease, but they were in remission for many years, and they were very well. But the COVID actually sort of induced the relapse. So they all had, my arrows have somehow run. They all had, as expected, raised T4, T3 and suppressed TSH. And their antibodies were all positive. The TRAP, anti-TPO, anti-TG antibodies were all positive. The thyroid uptake scan showed an increased iodine uptake, and the ultrasounds for those patients showed hypervascularity of the thyroid parenchyma. So they were all treated with methimazole, but I think what's interesting is that these patients required higher doses for a longer period, about 3 months. But subsequently, after 3 months, they were able to be, the doses were able to be reduced, and they could be maintained on lower doses of methimazole. Okay, so how does Graves' disease occur post-COVID? So I guess this is another list of reasons to put in our list for relapse of Graves' disease. Is COVID could be a trigger for new case or relapse of Graves' disease. And usually it's TRAP positive, and the treatment is with ATD, different with antithyroid drugs, different from subacute thyroiditis, where the treatment is usually steroids. Okay, so how it works is that your virus will then cause, so of course the virus affects your body, and then it will cause increase in your immune response. Okay, and during that increase in immune response, your thyroid autoimmune factors are also released, and because of that, you end up with Graves' disease. So that's summarizing the thyrotoxicosis. Now we look at primary hypothyroidism. How does COVID actually cause primary hypothyroidism? So there have been some reports of Hashimoto's thyroiditis caused by COVID. Okay, and patients actually presented with overt hypothyroidism, and this usually occurred 7 days after the resolution of mild COVID. All right, the anti-TPO was very markedly raised, so it's an immune-mediated complication. And even if you look at the study that I mentioned just now, they also found some patients who had hypothyroidism during hospitalization. So if you remember, I told you 20% of those patients had hypothyroidism. They found about 5% had hypothyroidism. A majority of those were actually subclinical, but 10% was actually overt. And what they found was that those patients who had hypothyroidism, especially the overt hypothyroidism, there was actually a negative outcome. It was negatively associated with the outcome of COVID, and it was associated with increased mortality. Okay, and most of the hypothyroidism actually persisted after discharge. So that's for hypothyroidism. There's not much data out there with regards to hypothyroidism, probably more in the future. And now we look at the third way that the COVID can affect the thyroid, which is the non-thyroidal illness. So I think as with any kind of illness, you can develop a non-thyroidal picture on your thyroid function. The same goes with COVID-19 as well. So this has been documented in ill patients where they have got a low T3, low or normal TSH with a low or normal free T4. Yeah, and it's been shown that there is a significant positive correlation between the severity of COVID-19 and the severity of your non-thyroidal illness. So it basically tells you that the more sicker you are, your picture will look, your NTI will be more severe. Yeah, and patients who recovered from the infection, the TFT normalized as expected. Yeah, so patients who had COVID-19 pneumonia, the mean TSH and T3 values were lower than the control compared to patients who had pneumonia from other causes. So COVID made you sicker compared to other causes of pneumonia. Yeah. So they postulated that the NTI the change in your TFTs is either caused by non-thyroidal illness, or it could be a unique effect of your SARS-CoV on your pituitary gland as well. Yeah, so I think that also remains to be seen. Yeah, and also you have to understand that all these patients who were treated with pneumonia, they were given steroids, and steroids can also suppress your TSH. So these are things to take into consideration. Okay, so now looking at how does thyroid dysfunction affect the prognosis of COVID? Whether is there a relationship that way? So what has been found is that those patients who had overt thyrotoxicosis in COVID-19, 32% developed AF, 16% developed thromboembolism. So they were at higher risk of developing complications. In hospital, mortality was also higher, and duration of hospital stay was also longer compared to COVID-19 patients who were just as sick with normal thyroid functions. So there is some sort of relationship between the severity of the interleukin-6, your systemic inflammation, and hyperthyroidism. So the higher your interleukin-6 is, the worse your hyperthyroidism would be. All right. And what about patients who have Graves? Are they at increased risk of developing COVID? So the data for now says that there isn't an increased risk of developing COVID just because you have Graves. Okay, but of course, if you do have Graves or hyperthyroidism and you have COVID, you can have more severe symptoms. Yep. So if you have uncontrolled hyperthyroidism, you get COVID, you can have more adverse cardiovascular effects, arrhythmias, hemodynamic instability, and even myocardial ischemia. All right. So this is the chart looking at in-hospital mortality in COVID patients stratified for serum TSH. So you can see in the third bar here, where your TSH is within normal, their range was 0.34 to 4.8. The hospital mortality was the lowest compared to when the TSH was either high or TSH was either low. Yeah. So those with normal thyroid function tended to do better compared to those who were found to have abnormal TFT. All right, so that's I'm done with my presentation. I'll just go to two very quick cases, clinical cases. If I have time, yeah, I think I have time, yeah. So case number 1 is a 72-year-old lady. She was a very well lady before. Hypertensive, dyslipidemia, diabetes were all very well controlled and very minimal amount of drugs. She presented to us with palpitations. She actually presented to the cardiologist with palpitations for 2 days. She actually denied having any neck pain, but she said she had some sort of sore throat. There was no tremors, no heat intolerance, but she did lose a bit of weight, about 1 kilo over 2 weeks. And she gave a history of recent COVID Cat2, slightly less than 2 weeks ago, before her presentation. And she has no family history of thyroid disease, no past history of thyroid disease. So on examination, she was a very thin, frail looking lady, but she was comfortable, she was not agitated. She didn't have any goiter, didn't have any neck tenderness, and no signs to suggest Graves like exophthalmos. And besides the heart rate of 110 in sinus rhythm, there were no other signs of thyrotoxicosis. So these were her bloods. Her initial T4 was 33 with a high T3 and suppressed TSH. So at that time, we sent off her thyroid antibodies, and we started her on carbimazole, and cardiology started on some bisoprolol for her heart. Her echo at that point was still okay. The ejection fraction was normal. Yeah. And 2 weeks later, her TFT actually improved markedly with from 33, it halved to 16, and the T3 became 6, and we cut down her carbimazole dose to 15. And now it's been 4 weeks since starting carbimazole, 4 weeks of treatment. Her TFT has normalized. The T4, T3 has normalized. The TSH, as we expect, will take some time to normalize. Her TSI came back as undetectable. And her technetium uptake scan was actually reduced at bilateral lower limbs. So carbimazole was stopped. So the diagnosis now is that could this be subacute thyroiditis or painless thyroiditis? So she didn't have any typical neck pain. She didn't have any neck tenderness, which is usually seen in most of the cases of subacute thyroiditis that have been reported. But the painless thyroiditis is usually seen in patients who are ill, admitted to hospital, which was not her case because she was just a COVID Cat 2 isolated at home. So it is definitely a form of thyroiditis, but which form it is, I think it still remains to be seen. So this is the first case that I want to bring up, and the second case is a 35-year-old man. He's had underlying Graves more than 10 years ago, and he's actually in remission. He's very well. It was not on any treatment. He had COVID Cat 2A in April this year, and then he presents a short 4 months later with thyrotoxicosis symptoms, very overt thyrotoxic symptoms, and there was no neck pain. So on examination, he was not anxious or agitated, but his heart rate was about 100, and he had a lot of tremors. He had some exophthalmos over his right eye, which he said worsened in the last 4 months. And you can see his T4 was very raised at 73 with a very raised T3 as well. And his TSI was very raised. I apologize, I don't have the reading with me, but it was a raised TSI. And he was started on carbimazole and propranolol. And with that, about 4 weeks later, his T4 didn't come down that much, from 73 to about 58. And T3 is 14, and so we maintain it on the same dose of carbimazole, because from the case reports it's shown that sometimes they need a higher dose for a little longer. So he's been treated as a relapsed Graves with a likely trigger of COVID-19. So these are the two cases that I want to present, and I think I'm done with my talk. I'll just summarize that COVID-19 has been found to have an effect on the thyroid as well. On top of all the other organs that it affects, the thyroid is also another organ that it has an effect on. It can be direct, that means through the virus directly affecting the gland, or an indirect way, which is through immune mediated. Okay, and it has been reported in the literature that it can be associated with the full spectrum: thyrotoxicosis, hypothyroidism, as well as non-thyroidal illness. Yeah, and COVID-induced thyrotoxicosis can be due to a subacute thyroiditis, painless thyroiditis, or even a new onset of Graves' disease. Yeah, and it's been shown that low TSH, low T3, and thyrotoxicosis in patients who are hospitalized, this appears to be a predictor of low outcome for these patients. So the question is, should we be doing TFTs in all patients with COVID-19? I think it's a bit too soon to say. We still need more data, because all this data we have is mostly case reports or sort of retrospective data. We still need more prospective randomized control data in order to make these cost-effective recommendations. And with that, I think we need to watch this space and wait for more data to come out. So with that, I'd like to thank you, and I pass the floor back to Prof. Shirini.
Thank you very much, Dr. Shamila. Very nice, comprehensive overview, and yet concise. Are there any questions for Dr. Shamila?
Excuse me.
Yes.
Yeah. Do you often see the vaccine-related endocrine disorder in Malaysia?
Pardon? Could you repeat that? Sorry.
Vaccine-related endocrine disease.
I'm sorry, we can't really make out the question.
Yes.
Sorry, could you please repeat?
I mean, in your clinical practice, do you often see the vaccine-related endocrine disorder?
Oh, vaccine-related endocrine disorder. I see. Yeah.
Yeah. I think we have seen a few anecdotal cases of worsening Graves. Patients who have been stable and then develop sort of relapse or worsening of their thyroid function after the vaccine. We have seen a few, and even the reports also say that there is reports of worsening thyrotoxicosis post-vaccine, and it's usually immune-mediated lah. But it's usually self-limiting, and it normally gets better with treatment.
And the effect is prolonged or temporary. The effect of the thyroid disorder is temporary or permanent.
Sorry, is it temporary or permanent? Is it? Oh, I think it depends. If it's thyroiditis, it usually resolves. But the case reports for hypothyroidism is not many, but they found that it actually can persist it's persistent in many hypothyroidism because it's already destructive. But for the subacute thyroiditis, it can actually resolve, and with Graves, with treatment, of course, it can improve. And of course, if patients don't respond, we have to proceed with definitive treatment.
Okay, thank you for your talk. Thank you.
Thank you very much. Thanks.
So we will now proceed with the next talk by Professor Lim. She will be talking about immune checkpoint inhibitor-induced thyroid dysfunction.
Okay, thank you very much, Prof. Rini, for the kind introduction. And it's our greatest pleasure to host this thyroid webinar between Universiti of Malaya as well as the Chang Medical Foundation. While waiting for the slides to be loaded, just give us 1 or 2 minutes on that. No, 30th August, the second. And then Zoom. Where is the Zoom? Hi, good afternoon. I'm Li Ling. I'm endocrinologist. So I actually present a few updates related to immune checkpoint inhibitors and thyroid dysfunction. So if you look at the first patient, she had recurrent metastatic breast cancer. The prior cancer therapy would have included mastectomy, radiotherapy, and chemotherapy. But she continued to have the type of immune checkpoint inhibitor since November 2020, where she was treated with pembrolizumab. And at baseline, prior to the initiation of immune checkpoint inhibitor, she had a normal free T4 and free T3, as well as a normal TSH with milli-IU per liter. But what we've seen here is after 3 weeks, after 3 weeks of the initiation of immune checkpoint inhibitor, ICI, what labeled here, she started to have a raised level of free T4 and a raised level of free T3, as well as the suppressed TSH, signifying primary hyperthyroidism picture. 6 weeks later, what we've seen is actually a totally opposite thyroid profile with a suppressed level of free T4 and free T3, as well as a raised TSH level. Just keep in mind about this first patient, a 40+ years old lady. If we move to the second patient, will be a man with a 60 years old. He had non-small cell lung cancer with brain metastasis. Previously had been treated with a stereostatic brain surgery. He was commenced with the semiplimab since April 2020. And what we've seen from here, the only baseline thyroid function test that we had prior to the initiation of the immune checkpoint inhibitors would be a normal TSH level. But slightly different from the first case would be 3 months later, a thyroid function test was checked. Similarly, would be a primary hyperthyroidism picture with a normal free T4 with a suppressed TSH. But 10 months later, again, we see a totally opposite profile with a suppressed level of free T4 and a raised TSH level. We can actually take about 10 seconds thinking what had happened to both of our patients. Could it be these two patients had underlying thyroid disorder we only decided to surface now? Or you think that there could be a possibility of thyroid assay interference because within, especially like for the first patient, you do notice a totally opposite thyroid hormone profile just within a few weeks' time. Or it could be related to their cancer therapy. I'll allow about 10 seconds just to think about it, and before we proceed with a further presentation. Okay, so of course, because this could be related to my presentation, the definite answer will be C, is related to immune checkpoint inhibitor therapy. I am not an oncologist, but in order to understand why our oncologist colleague would actually try to use immune checkpoint inhibitors, and this seems to be the newer era of the cancer therapy. If you look at the pathophysiology of how cancer works, looking at the first step will be activation of T cell. What you see from here on your left will be the antigen presenting cell, and on your right will be T cell. The T cell receptor requires binding with a major histocompatibility complex, and the CD28 will need to bind to B7, and with these two combinations with an activated T cell to prevent tumor cells proliferation. In the presence of CTLA4, which is a competitive agonist to CD28, meaning CTLA4 will compete with CD28 to bind with B7, the higher level of CTLA4 that you had would be not good. So because the higher level of CTLA4 will actually bind to B7, and hence you won't be able to activate T cell, and you won't be able to prevent the tumor cell activity. If we administer an anti-CTLA4, this will actually directly reduce the activity of CTLA, and hence won't compete with CD28, and you will actually expect a good anti-tumor activity because you were able to activate T cell. And on the other hand is T cell exhaustion pathway. Again, cancer or host cell will be on your right. T cell receptor bind to the MHC complex. You have PD-1 will also bind to PD-L1, and this pathway would have led to T cell exhaustion, leading to proliferation of cancer cells. If we inhibit the PD-1 activity or even PD-L1 activity, there will be less T cell being exhausted, and this will provide good anti-tumor activity. If we look at a review, I tried to summarize the list of the FDA-approved immune checkpoint inhibitors. This is not meant to be exhaustive, just trying to introduce what would be the potential ICI, immune checkpoint inhibitors, that we have nowadays. There will be 3 different targets, whether it's the anti-CTLA4, anti-PD-1, and PD-L1. Just reiterate what we presented just now in my previous slide will be anti-CTLA4, it will include ipilimumab, nivolumab, pembrolizumab, or even with the cemiplimab, which I presented for our second patients. They belong to the anti-PD-1 group. And you also have other such as avelumab and durvalumab as the anti-PD-L1 immune checkpoint inhibitors. If you look at the pathophysiology, how can immune checkpoint inhibitors cause endocrinopathies derangement in terms of the hormonal profiles? They are key regulators of immune tolerance, the CTLA, PD-1, and PD-L1, and they will actually promote cell-mediated destruction of the tumors. And physiologically, these molecules prevent autoimmunity, and if you block them, this would actually trigger autoimmunity and inflammation, and hence we are seeing a higher incidence of endocrine abnormalities by organs and by the type of immune checkpoint inhibitors. If you look closely at this figure, they're trying to map what would be the type of incidence that we would expect by different types of organs, as well as by the different types of immune checkpoint inhibitors. Red represents the anti-CTLA4, dark blue will be PD-1 or PD-L1, and purple color will be combination therapy of immune checkpoint inhibitors. Thyroid dysfunction is the most common across the board, followed by pituitary, adrenal, and pancreas manifesting similar to type 1 diabetes. And again, another interesting finding from this figure would be looking at the combination therapy, they actually produce the highest incidence of endocrinopathies associated with compared to monotherapy. So what would be the common risk factors that we see that could be associated with a higher incidence of ICI endocrinopathies? This table has summarizes a few. It can be demographic. It can also be related to the type of immune checkpoint inhibitors, as well even at the baseline autoimmunity level that a person has. Female versus male. Female is the susceptible group. Younger patient, pretty similar as what we tend to see for autoimmune disease. Asians tend to be has a less risk of having ICI-associated endocrinopathies. Reiterate, combination therapy has the highest risk with a longer duration. The type of the baseline autoimmunity, if you have a higher thyroid antibody, like the anti-TPO, anti-thyroglobulin, this group of people actually had a higher chance of developing hormonal abnormalities after exposure to any types of immune checkpoint inhibitors. This figure, some of the information overlap with the previous slide, but I would like to highlight here that this is the most recent review in the Frontiers Immunology. They actually be more specific in terms of the specific patients group who could have a higher chance of developing endocrinopathies. Young people, that specific cutoff age of younger than 60 years old, patient who smoke a longer duration of smoking, you have any types of autoimmune condition, as well as gender specific, like in women, if you have been predisposed to the anti-CTLA4, seems to be at a higher chance, or even with a non-specific risk factors, whether you have sarcopenia, or you have a higher disease burden, you have a higher tumor mutational burden. So all these are the potential trigger factor for endocrinopathies. We know that thyroid dysfunction is the most common types of ICI-associated endocrinopathies. Then what about the onset? How soon will we expect our patients to have developed and all these hormonal disturbances? Looking at the third row with thyroid dysfunction, the median onset will be about 6 weeks. If you look at the primary adrenal insufficiency, it's about 3 to 24 weeks, on average, quite a broad occurrence, the interval needed. What about diabetes? About 7 weeks, the minimum period. And for hypophysitis, it depends on the type of ICI. If a patient has been treated with anti-CTLA4, the median onset for hypophysitis is about 9 weeks. If it's an anti-PD-1 or PD-L1 exposure, it's again longer, it's about 6 months duration. This is from the MD Anderson Cancer Center. They look at about 43 cancer patients who have been exposed to different types of immune checkpoint inhibitors. They also they examine the time to thyrotoxicosis will be median for about 5 weeks, and the time to hypothyroid about 10 weeks. And interestingly, for patients who have developed thyrotoxicosis, the entire thyrotoxic phase would last for about 5 weeks on average. But if a person develops hypothyroidism, the interval of hypothyroid phase will have last up to about a year, 60 weeks in duration. Showing here will be from the MD Anderson data as well. They look at different types, the timeline of thyroid dysfunction by the type of immune checkpoint inhibitors, and being analyzed here will be commonly the patients have been treated with combination therapy, whether it's ipilimumab or nivolumab, versus monotherapy, whether it's nivolumab or pembrolizumab. Looking here, just two key points that I would like to highlight would be combination therapy tend to have a higher risk of developing immune checkpoint inhibitors associated thyroid dysfunction versus just monotherapy alone. And remember, even within the same class of the immune checkpoint inhibitors, nivolumab and pembrolizumab, they belong to the anti-PD-1. The onset of thyroid dysfunction could also differ. Showing here, pembrolizumab patients who have been exposed to pembrolizumab tend to experience thyroid dysfunction earlier than patients who have been treated with nivolumab. Trying to compare would be the clinical characteristics that our patients may present to us if, let's say, the thyroid dysfunction had set in. First would be the timeline to thyrotoxicosis would be about 5 weeks. I presented in the figure, the timeline figure just now. Usually in general, the onset of the overt thyrotoxicosis occurs earlier and persists longer than subclinical thyroid dysfunction. And the overt thyrotoxicosis patients, they can have a higher baseline level of thyroid antibodies. And remember, the thyroid antibodies may also increase with a longer duration of ICI exposure. There are some patients who tend to have more severe symptoms, and we may need to relook whether this patient could have underlying thyroid disorder, so additional thyroid features, where the presence of grave ophthalmopathy, whether there's goiter, and you could actually consider sending off the TSH receptor antibody. Then what about patients who may come to us with hypothyroidism? And mainly the clinical phenotype would be subclinical hypothyroid, which tend to be self-limiting. But also there are a group of people, as what I presented here, the first and second cases, they tend to have overt hypothyroidism. And these patients may have permanent disease with lifelong levothyroxine replacement. So this is a figure which summarizes how do we manage immune checkpoint inhibitor associated thyroid dysfunction. If we concentrate on the left-hand panel, if we see a patient having a suppressed TSH, but with a normal free T4 and free T3, these patients would have subclinical hyperthyroidism and will actually repeat thyroid function after 6 weeks with monitoring. But if, let's say, patients presented with primary hyperthyroidism picture, just like the first two cases that I presented, these patients were overt hyperthyroidism, but do we treat using anti-thyroid drugs? In general, is not indicated. We may consider beta blocker if patients does have symptoms. Bear in mind, we know about the natural history of progression of thyroid dysfunction with ICI. If you look at your right-hand panel, if a patient having an elevated TSH, but with a normal free T4 and free T3, this is subclinical hypothyroidism and hence will track the thyroid function after 6 weeks. But again, a patient presented to us with primary hypothyroidism picture, high TSH, but with a low level of free T4 and free T3, we will diagnose the patients having overt hypothyroidism and hence we need to convince levothyroxine therapy following our usual standard guideline in general would be 1.6 microgram per kilogram per day. Question that we tend to ask is, do we need to give steroids because it's a sort of like a thyroiditis, or do we need to discontinue the immune checkpoint inhibitors? And the answer in general is no. Discontinuation of ICI is currently not recommended, and the use of steroids is not a routine in managing ICI-associated thyroid dysfunction. So we're back to our patients, looking just side-by-side comparison. Is a lady versus a man, younger lady, older man, different types of the within the same class but different type of drugs, pembrolizumab versus cetuximab. The presentation alone could differ. The lady, higher incidence, higher chance of developing thyroid dysfunction as early as 3 weeks versus a man of 3 months, and within 6 weeks, upon the exposure to ICI, she would have developed overt hypothyroidism, whereas in this man, the second patient, only 10 months later. The thyrotoxic phase of the lady tend to be greater. She was symptomatic with a higher free T4 and free T3 level, and hence she needed a temporary dose of propranolol or beta blocker for symptomatic relief, but both of them require permanent levothyroxine replacement until today. So with that, thank you for your kind attention, and over to you, Prof. Srini.
Thank you very much, Li Ling. Very nice talk, a good overview of something that's very topical. Are there any comments or questions from the audience? So if there are no comments and questions, perhaps we'll go on, hand the mic over to my colleagues in Taiwan for the third presentation.
Thank you for Professor Ratna, your kind introduction. I'm Dr. Benson, the Director of Endocrinology and Metabolism Division in Chang Memorial Hospital, also the President of the ESRC Taiwan. It's a great pleasure to introduce the next speaker, William Zhou. Dr. Zhou is a bachelor degree, double major medicine and traditional Chinese medicine in Chang'an Memorial Hospital. He is now the attending physician of Chang'an Memorial Hospital Lab Lincoln. He is passionate about developing minimal invasive treatment of thyroid nodule and exploring new thermal ablation of thyroid. Today, his topic is radio frequency ablation, the minimal invasive intervention for thyroid nodule. Let's welcome Dr. Zhou.
Okay. Good afternoon, Professor Liu and Professor Physicians in Malaysia. I am Dr. Wei Yu Zhou from Chang'an Memorial Hospital in Taiwan. I'm going to talk about the minimal invasive intervention for thyroid nodules, from physics, theory, clinical management to training program. These are two pictures of my patient. We could clearly see that enlarged thyroid nodules not only will cause compressive symptoms, but also will cause serious cosmetic problems. Thyroid nodules are very common. According to American Thyroid Association guidelines and previous study, up to 45% of women and 18% of men would detect thyroid nodule in a Danish ultrasound research. Out of these series showed even higher prevalence. Prevalence in women is 1.5 to 1.7 times higher than men. The main cause of thyroid nodules is still unclear, but iodine deficiency area had higher occurrence rate. Before 1960s, Taiwan Aborigines have high incidence of thyroid goiter around 50%. In one local research, 21% of school children have enlarged thyroid goiter. Our government started aid iodine to our salt since 1964, and 4 years later, prevalence has dropped from 21% to 4%. Except iodine deficiency, genetic factor also played a crucial role in goiter formation under some specific observations, like clustering of goiter within families, high concordance rate in monozygotic twins, etc. The including gene includes sodium iodide importer, thyroid peroxidase, and well-known pendrin. When a nodule goiter causes some discomfort and inconvenience, like hyperthyroidism-related palpitation, weight loss, heart failure, even more thyroid storm, compressive goiter with supine dyspnea, dysphagia, or tracheal compression, or if have any cancer concern, thyroidectomy become a treatment choice. The conventional treatment of thyroidectomy would remove the thyroid gland by surgical approach. This method could solve the problem and eliminate the malignant concern, but this will certainly bring some bothersome adverse effects. These are the surgical complications after thyroid surgery. The common complications including hypocalcemia, hypothyroidism, and vocal cord palsy. Of course, scarring from conventional surgery is unavoidable, and this often causes problems in the appearance. Previous study in JCEM revealed that 2/3 patients receive lobectomy would occur early or late hypothyroidism. 12% of patients will potentially need thyroxine replacement. Scarring and postoperative hypothyroidism are two of long-term complications that doctors are eager to avoid. Thus, thermal ablation techniques are considered cost and risk effective in fulfilling the patient's demand. Minimizing scar, decrease size, most importantly, without causing hypothyroidism. The thermal ablation had two major guidelines. The left one is from Korea. Koreans developed radiofrequency ablation for many years. They published radiofrequency ablation guideline in 2017. The right one is from Europe. They published the guideline in 2020. The first recommendation from European guideline is benign thyroid nodules cause pressure symptoms and cosmetic concerns and decline surgery. Thermal ablation should be considered. Thermal ablation includes laser, RFA, HIFU, and microwave. These are the main treatment options today. Each method has its advantages and disadvantages. High-intensity focused ultrasound as HIFU is the only treatment without wounds, but that's effective in cystic component and large nodules. Very expensive and time-consuming. Laser is a focused beam of light energy delivered through an optical fiber into the target tissue. Laser has the thinnest electrode and the lowest mean applied power between the various thermal ablation techniques, but less effective than RFA in meta-analysis study. RFA and microwave have similar operation skill, moving shut. They all need advanced treatment skill. The learning curve is relatively long. The two treatment results are roughly equivalent. There are some advantages of RFA, and the RFA electrode is thinner than microwave, so less hematoma could be expected. And during ablating the nodules, heat would cause carbonization and compromise our volume reduction rate. RFA works according to tissue impedance. If the tissue impedance above 800 ohm, RFA device will stop to avoid further carbonization. This is the picture of microwave and RFA ablation in liver mimics. The left one is result from microwave, and the right one is from RFA. After ablating, there is an obvious carbonized area in the middle of the microwave phantom, whereas In the right picture, RFA ablates a larger area, but there is no carbonization. Macrophage cannot enter the carbonized area and absorb the damaged tissue, making the ablation less effective. This might explain why RFA is more effective than microwave. Patient selection and preparation. A benign cytological diagnosis is needed before planning thermal ablation. Thus, confirmation with a repeat fine needle aspiration or core needle biopsy is needed. Ultrasound examinations is important to evaluate the surrounding critical anatomical structures, to characterize the nodule size, echogenicity, proportion of solid component, and internal vascularity. Symptom and cosmetic scores should be determined before RFA for comparison with follow-up data. Now we're going to talk about the physics and device. Application of radiofrequency current to tissue agitates ion as they tend to follow changes in the direction of alternating current. Such agitation creates frictional heat around the electrode, causing protein denaturation and cell death. Simultaneously, tissue removed from the electrode is heated slowly, while thermal conduction from the center of the ablation zone to the peripheral zone. And this is the growth specimen after thermal ablation. In the ablate mass, we could see necrotic materials and whitish pseudo wall formation. This result revealed thermal ablation would cause necrosis and size shrinkage after the procedure. This is the schematic of thyroid RFA. An operation bed, of course. Patient was in lay down position with 2 ground pads on their sides, a generator to provide the ablation energy. Generally, we use 5 to 60 watts for ablation, and a foot switch to control the generator. And we also need a water pump to cool down the electrode, keep the tip temperature around 10 degrees Celsius. Next, we will introduce the indication of RFA. The first one, of course, is benign thyroid nodules, from solid nodules to mixed lesions. Nodules cause cosmetic problems. The third one is autonomous functioning thyroid nodules, or aim to relieve compression, or even more, inoperable cancer. There are some techniques during the RFA. The most well-known 2 skills are transismic approach and moving shock technique. The transismic approach and moving shock technique are 2 fundamental methods for thyroid RFA. The transismic approach refers to the insertion of a radiofrequency electroviolet isthmus in the mid-time to lateral direction. There are several advantages in using transismic approach. First, the operator can monitor the association between the electrode, target nodule, and the recurrent laryngeal nerve, which is situated in the so-called danger triangle between the trachea and the thyroid gland. Constant monitoring of the relationship between the active tip and the recurrent laryngeal nerve is very important for prevention of possible thermal injury. Second, the normal isthmic parenchyma between the target nodule and the electrode insertion site prevents the leakage of hard ablate fluid to the perithyroidal area, which would otherwise cause pain. Finally, use transismic approach. The electrode position remains stable even when a patient talks or coughs. Of course, under specific conditions, we could also use lateral approach or cranial caudal approach. The knowledge of nerve location and variation is important in preventing nerve injuries. Intra-procedural nerve injury results in various symptoms ranging from purely transient to permanent, that depend on the severity and duration of the injury. There are three most important nerves in the thermal ablation of thyroid. The first one is recurrent laryngeal nerve. The second is vagus nerve. And the third is cervical sympathetic ganglion. And we'll talk about the normal findings and the common variants in the following slide. The first is recurrent laryngeal nerve. Recurrent laryngeal nerve injuries cause symptoms such as voice change and cough, and is usually caused by an injury during biopsy or minimal invasive treatment. Minimizing heat exposure to the tracheoesophageal groove is crucial to prevent complications. There is a well-known variant, non-recurrent laryngeal nerve, because the right non-recurrent laryngeal nerve is associated with the aberrant right subclavian artery arising from the aortic arch, and the left non-recurrent laryngeal nerve is associated with situs inversus. Ultrasound can predict the variation with identification of the absence of the brachiocephalic trunk. The division of the brachiocephalic artery into common carotid artery and subclavian artery has been described as the Y sign. Hence, operators should look for the Y sign to rule out the possibility of a non-recurrent laryngeal nerve. Second is the vagus nerve, which is the longest cranial nerve. The cervical course of the vagus nerve can be easily visualized on ultrasound as a 2 mm to 3 mm structure. It is typically located within the carotid sheath and is usually posterolateral to a common carotid artery and posteromedial to the internal jugular vein. There are 4 common variants on the slides. We need to be more cautious if the vagus nerve variation is over 10 o'clock or 6 o'clock. This type and this type. It's easier to have thermal injury during ablation. The third related nerve is middle cervical sympathetic ganglion. 2 anatomic variants of location of the ganglion, medial and lateral types. The lateral types account for 88%, is more common type and is located posterior to the carotid sheath. In contrast, the medial type accounts for 12%, is located between the thyroid gland and the common carotid artery. It's easier to have thermal injuries in medial type middle sympathetic ganglion, and it would cause Horner syndrome. In conventional RFA of other organs such as liver, the active of the electrode is fixed to the center of the target tumor. However, the thyroid glands are difficult to ablate using this technique. Using fixed technique, thyroid nodules and surrounding tissues may be undertreated or overtreated. Thus, moving shot technique may be a better option. We could see that after 2 minutes ablation, comparing to fixed electrode, the moving shot technique could deliver more energy and ablate larger volume at the same time. Thus, moving shot in thyroid RFA is better than fixed electrode method. How about the efficacy of thyroid RFA? This is the picture of the patient I brought out previously. 3 months later, his goiter shrinkage and with a satisfactory result. The other woman we mentioned in the beginning. Her initial size is more than 8 centimeters, and after 6 months later, her appearance had a great improvement and regained her voice. Dr. Beck published the paper in 2011. The average volume reduction rate is 45% in 1 month, and followed by 73% in 6-month follow-up. This is our result. We divided case into 3 groups based on nodule size. The blue group is less than 5 cc, and the red one is between 5 to 30, and the orange one is larger than 30. As a general rule, the smaller the treated nodule, the higher the volume reduction, so size matters. Another, as tissue structure affecting the alternating current flow, compact tissues are more resistant than soft tissue. Cystic lesions, spongiform, and mixed lesions respond better than solid lesions. So content matters. Let's talk about the complication of thyroid RFA. In 2017, Korean doctor published the complications in the European Journal of Radiology. They recruited 875 patients. The overall complication rate was 3.5%, and major complications including voice change, Horner syndrome, and tumor rupture. The incidence was low, only 1.6%, and only 0.5% of patients had persistent symptoms. Therefore, a lower complication rate of RFA can be expected. RFA is well known as a skill need a long learning curve. We started RFA not for a long time, but we still can reach the average result, fair nodule reduction rate, and very low adverse effect. This achievement is all due to a good training model, which allows us to get started quickly. We published a medical educational paper about how to train physicians to perform RFA on Frontiers in Endocrinology this March. We used a food assist and simulated training model of thyroid RFA for young endocrinologists. Chicken heart was stimulated into thyroid nodules and 3-layer pork was stimulated into parathyroid structure. If pork is not suitable, might change to steak, but it's more expensive. And gel bottles were stimulated into trachea respectively. And this is the ultrasound image during training. We insert electrode into the thyroid nodules and start ablate the deep area. The thermal ablation would cause hyperechoic bubble. In order to prevent limitation of the acoustic window by air bubbles, the electrode can be initially positioned in the deepest and most remote portion of the nodule, with subsequent retraction to the most superficial portion. We repeat the movement until we ablate a whole nodule. It's very important to keep the whole needle image on the screen to avoid parathyroid damage. The successful ablation were defined as color of chicken hearts, from bright red to off-white, indicating that the meat was fully cooked. This allows us to evaluate if ablation is sufficient or not. This is the total reduction rate by year. The blue one is the volume reduction rate curve in 2020, and the red one is in 2021. We could see that volume reduction rate does improve in the next year. It demonstrates that learning curves does exist, and our training model could help young staff in the beginning years. Besides benign thyroid lesions, further application might considered extend to low-risk papillary thyroid microcarcinoma. The previous paper published in July 2020, they enrolled more than 400 patients who had unifocal low-risk papillary thyroid microcarcinoma. After RFA, 88% tumor completely disappeared. A total 13 patients underwent additional RFA and 11 lesions completely disappeared during the follow-up. This is another paper comparing RFA and surgery in solitary papillary thyroid carcinoma. We could see the tumor nearly completely disappeared in the RFA group after 18-month follow-up. Comparing RFA and surgery, there was no significant difference in local tumor progression. But in surgery group, 4 patients had permanent hypoparathyroidism after the procedure, while no major complications were observed in the RFA group. Thus, compatible results and avoid permanent complications. RFA might be considered in low-risk PTMC. Here comes the summary. Advantage of RFA are there are no scars. It was minimal invasive, easy procedure, and acceptable result and easy retherapy. Quick recovery, only need local anesthesia. Rare major complications. Nearly no affecting the thyroid function. And a procedure treatment could be carried out in an outpatient facilities. Furthermore, we might explain the procedure to low-risk PTMC, reduce possible permanent iatrogenic damage during treatment. And this is the end of my presentation. Thanks very much.
Thanks, William. How many cases you performed in this hospital?
In our team, we've already performed more than 150 cases in our hospital.
Is there any complication or major complication you met?
No major complications, only minor complications. Transient voice change. Yes, I have 2 patients have transient voice change, but they all recovery after 1 day of the surgery.
How do you do when during the procedure, patient got voice change? How do you correct the condition? During the operation, patient got voice change.
We have to find the reasons. The reasons for change in voice change during RFA are 1, lidocaine leaks and affect nerves. Second, tissue swelling is related to physical compression. The third one, heat conduction affects nerve function. If vocal change do occur, we will check for vocal cord movement by ultrasound and inject 5% dextrose water with hydrocortisone into the tracheal esophageal groove. In our experience, patients recover their voice after 10 to 15 minutes.
And how about the bigger one? The larger nodule, you need second chance to reduce the size?
The nodule will shrink faster during 3 to 6 months and relative steady state in 6 months. Thus, we'll follow up this patient and decide whether an additional treatment is needed 6 months after the initial treatment.
Okay, thank you for your nice talk. Is there any question from our audience?
Really enjoyed your presentation. Could I ask you, have you observed any cases of transient thyrotoxicosis after your RFA procedure?
Yes, we do have 1 patient with transient toxicosis, but we only give the patient for propranolol for symptom relief, and 1 month later the symptom relieves and the lab data is normal.
So do we have to routinely monitor these patients? Do you advise us to routinely monitor patients after the procedure?
Yes.
Their thyroid function.
We ask the patient, or we tell the patient to come back to our clinic 1 month, 3 months, and 6 months after the initial treatment, and we'll do the lab examination and the ultrasound evaluate the nodule condition. So as far as we do this, there's only one patient has transient thyrotoxicosis. Oh, thanks for the question.
Thank you very much for your talk. And I must say, I enjoyed the chicken liver bits as well. It's made me very hungry.
Very impressive. No, it's a very nice, the first touch between University of Malaysia and Chang Memorial Hospital and Endocrinology Department. It's my great honor, and I hope it's a good start, and we can perform another talk, maybe something like other endocrine disease. We can share the experience or case or other papers for further discussion. It's my great honor to have you with me this afternoon. Thank you very much.
Can you hear me? Thank you very much as well to all the presenters. It was really nice sharing information, and we hope to do this again in collaboration with Gung Memorial Center. Thank you very much. We really enjoyed this session.
Okay.
Thank you.
Thank you. Thank you very much.
Thank you. Bye.
Bye bye.
Bye-bye.